This is Dr. Vermilio. In this lecture, we'll continue our lecture on pure tone testing. This is called a bone conduction vibrator. This allows an individual to hear the test tones when they are delivered via bone conduction. Specifically, see this little black box sitting behind the patient's ear. That little box will vibrate the skull when a pure tone is delivered, and the patient will be able to hear the pure tone, of course if the auditory system is normal, through this box. This little box, this bone conduction vibrator, actually bypasses the external ear canal, and it bypasses the middle ear to a large degree, and the patient hears through bone conduction. We can deliver pure tone thresholds to the patient. We can also deliver speech sounds to the patient excuse me, through a bone conduction vibrator. Test signals are delivered to both cochlea or cochleae through skull vibrations. Masking noise may be presented to the non-test ear in order to prevent it from hearing the test sounds delivered to the test ear. So the test ear will hear the pure tone, and then the masking noise will be delivered to the non-test ear to keep it busy so it's not responding. So the patient's not responding because they hear the test tone in the non-test ear. We want to test the test ear. Masking noise is not necessary for every patient, but in certain conditions it is required. Test signals are generally audiometric frequencies from 250 to 4,000 hertz. We don't have test tones at a higher frequency due to the limited bandwidth of the bone conduction vibrator, also known as the transducer in this case. So we actually cannot produce 6,000 hertz in most bone vibrators, and certainly 8,000 hertz is not produced with the bone conduction vibrator. There's a limited maximum output across test frequencies, so we cannot test at all levels for each of the frequencies because, again, of the limited output from the bone conduction vibrator. Air conduction versus bone conduction thresholds. Air conduction thresholds are obtained through the use of insert earphones or supraoral earphones or even circumoral earphones. That's air conduction, for air conduction testing. Bone conduction thresholds are obtained through the use of a bone conduction vibrator, or oscillator it's also called. The non-test ear must be masked, again, when appropriate. A comparison of air conduction thresholds is used to determine the type of loss. A comparison of air and bone conduction thresholds is used to determine the type of hearing loss. So if somebody asked you to look at an audiogram and to tell them what type of hearing loss do I have, you would have to look at the air conduction thresholds, you'd have to look at the bone conduction thresholds, and make a determination regarding the type of hearing loss. A conductive loss, that's one of the types of loss. A conductive hearing loss is one where sound is decreased as it passes through the external or middle ears. So a conductive hearing loss means that the side of lesion, or the part of the ear that isn't functioning within normal limits, is either the external ear canal or the middle ear. Where when you have air conduction thresholds at least 15 dB poorer than bone conduction thresholds. So imagine a bone conduction threshold basically within normal limits, so it's equal to or less than 25 dB HL, and the air conduction threshold is 15 dB poorer or 15 dB higher than the air conduction threshold. That is called an air-bone gap, and that's a conductive hearing loss, and that's a sign that the problem is in the external ear canal or the middle ear. Now, so to reiterate, when the air conduction thresholds are poorer than the bone conduction thresholds, an air-bone gap is present and is indicative of a conductive hearing loss. When the bone thresholds are less than or equal to 25 dB HL, or this is called a mixed hearing loss if the bone conduction thresholds were elevated, meaning greater than 25 dB HL. When air conduction thresholds are equal to bone conduction thresholds and they are greater than 25 dBHL, this is indicative of a sensory neural hearing loss. When air conduction thresholds are equal to bone conduction thresholds and they are greater than 25 dBHL, this is indicative of a sensory neural hearing loss. When air conduction thresholds are equal to bone conduction thresholds and they are equal or less than 25 dBHL, this is indicative of normal pure tone thresholds. So commit all these ideas to memory. When the bone conduction thresholds are poorer than air conduction thresholds, though theoretically impossible, this may be due to the positioning of the bone vibrator or to the anatomy of the patient's skull. Air conduction thresholds are represented by the symbols an open 0 and an X. So the 0 symbol represents the right air conduction thresholds. On some audiograms, you'll actually see them in red. And the X represents the left air conduction thresholds. These are both unmasked air conduction thresholds for the right and left ear. The symbols used for bone conduction thresholds would be this sort of V symbol on its side. When it opens to the right, that's for the right bone conduction threshold. When it opens to the left, that's for the left bone conduction threshold. The right bone conduction thresholds are put on the audiogram when we put that bone conduction vibrator behind the right ear. The left bone conduction thresholds are placed on the audiogram when we are testing with the bone vibrator behind the left ear. These symbols that you see on this slide are both unmasked bone conduction threshold, meaning that there was no masking noise presented to the non-test ear. When the air conduction thresholds, actually we just talked about this. Okay, again, when the air conduction thresholds are poorer than the bone conduction thresholds, an air-bone gap is present, indicative of a conductive loss. And notice this, the bone conduction thresholds will determine, the placement of the bone conduction thresholds will determine if the loss is a conductive loss or a mixed loss. Okay, we reviewed this. Now let's go to this graph. So let's say we're testing individual frequencies and we see air conduction threshold results and bone conduction threshold results for the right ear. And let's look frequency by frequency. This graph is not an audiogram. This is just for illustrative purposes. Let's look at this first panel. You see that the air conduction threshold and the bone conduction threshold are equal. They're both 15 dBHL. They're both better than 25 dBHL. So what type of loss does that represent? Well, actually, it represents normal pure tone thresholds. It represents, a lot of people would say this represents normal hearing, and that since the air conduction threshold is better than 25, that means that the pure tone threshold is within normal limits. Now, remember the definitions, and let's look at this next panel. You see the bone conduction threshold is better than or lower than 25 dBHL. The air conduction threshold is at 40. So do we have an air bone gap greater than 15 dB? What's 40 minus 15? Yes, we have an air bone gap. We have an air bone gap, and the bone conduction threshold is better than 25 dB, so that represents a loss, right? Because you look at the air conduction threshold, it's worse than or greater than or higher than 25 dBHL. That's a hearing loss. Next question is, what type of loss is it? We're going to use the bone conduction threshold and the air conduction threshold, and we're going to decide that it is what? Right, a conductive hearing loss. Where is the site of lesion with the conductive hearing loss? Or where is the problem for this ear with a conductive hearing loss? Right, the problem is in the external ear canal and or the middle ear. Next panel, both the air conduction threshold and the bone conduction threshold are poorer than or greater than 25 dBHL. What type of loss is this? Is there a conductive component? Well, the air conduction threshold and the bone conduction threshold are equal, so there's no air-bone gap, so there's no conductive component. So we would say that the site of lesion is not in the external ear canal or the middle ear. So what type of loss is this? Right, it's a sensory neural hearing loss. So where is the site of lesion, or where is the problem in the auditory pathways? The problem may be in the cochlea. That's where we get the word sensory. It may be in the eighth nerve or any of the neural pathways going through the brainstem and up to the brain. That's where we get the term sensory neural hearing loss. Actually, all sensory neural hearing loss means we don't know where the problem is. We just know it's not in the external ear canal, and we know it's not in the middle ear. So it's from the cochlea on up. We don't know exactly where it is. We could determine the site of lesion by using other tests, but we can't determine that with just air and bone conduction thresholds. The next type of loss, the next panel, bone conduction symbol is the threshold is poorer than 25 dBHL or higher than 25 dBHL. And the air conduction threshold is also poorer than 25 dBHL, and we have this thing called an air-bone gap. So do we have a conductive component here in this loss? And the answer is yes. And because we have a conductive component with that air-bone gap, that means the site of lesion is in the external ear canal and or the middle ear. Now, is this called a conductive loss? Well, we say we have a conductive component, but the type of loss is not a conductive loss because the bone conduction threshold is now poorer than or worse than 25 dBHL, so we have a mixed hearing loss now. A mixed hearing loss has a conductive component. There's also a sensory neural component because the bone conduction threshold is poorer than 25 dBHL. So this is the classic mixed hearing loss. Now look at the last panel. The air conduction threshold is better than the bone conduction threshold. So first question, does this represent a type of loss? And the answer is no, because we determine if there's a hearing loss for pure tones by looking at the air conduction threshold, which is within normal limits because it's better than 25, equal to or better than 25 dBHL. So there is no hearing loss, but do we have an air-bone gap? Well, actually, theoretically, this is impossible. You can't have better hearing through air conduction than bone conduction. So theoretically, this is impossible. Do we ever see this sort of upside-down air-bone gap? Does that exist in real life? And the answer is yes. We see it all the time. Most likely, it's due to misplacement of the bone conduction vibrator, or it could be due to the presence of a surgical site on the skull. So perhaps there's a metal plate in the head if the patient was in, say, an automobile accident, or if the skull had been fractured. Those conditions can result in unusual bone conduction thresholds. Is this an air-bone gap? No. Is there a conductive component? No. Conductive components only occur when the air conduction threshold is worse than or poorer than or higher than the bone conduction threshold by 15 dB or more. So this configuration does not represent a hearing loss. It does not represent a conductive hearing loss. The pure tone threshold is within normal limits, and most likely this is due to either the placement of the bone vibrator or the configuration of the skull itself. So we're going to call this a normal pure tone threshold. Now let's look at this figure from the Kramer textbook, figure 5.8, and we see representations of a sensory neural hearing loss, a conductive hearing loss, and a mixed hearing loss. And know this, that even though these are really nice examples, you can see audiograms where you might have a conductive component in the low frequencies, an air-bone gap in the low frequencies, and a sensory neural component in the highs. Or you might have a sensory neural component in the low frequencies and a mixed loss with a conductive component in the highs. So you can see all sorts of configurations. What you need to do is look at the air conduction threshold and the bone conduction threshold for each frequency and answer the question, what type of loss is it? Notice at 250 hertz for this audiogram, this does not represent a pure tone threshold loss because the pure tone threshold represented by this X is within normal limits. It's either 25 dB HL or better. Because we do not have an air-bone gap, this would represent a normal pure tone threshold at 250. But because the air conduction threshold is poorer than 25 dB HL, this represents a sensory neural hearing loss. And so does this frequency, also at 2,000 and 4,000 hertz. Notice there is no bone conduction symbol at 8,000 hertz, and that is because of the limitation of the output of the bone conduction vibrator. We cannot measure a bone conduction threshold at 8,000 hertz. But the overall picture, and again, we're going to decide the type by looking at the overall picture. So we'd say overall we have a sensory neural hearing loss. We actually have a high frequency sensory neural hearing loss. You could put in the report that the test results for 250 hertz are within normal limits. Over here we have a conductive hearing loss. Recall that the bone conduction threshold is equal to or better than 25 dB HL, and we have an air-bone gap of 15 dB or more, and that's the classic example of a conductive hearing loss. Where is the site of lesion, or where is the problem in the auditory system for this loss? Right, it's in the external ear canal and or the middle ear. Where's the site of lesion or the site of the problem for this type of loss? Right, it's in the cochlea. That's where sensory comes from. The cochlea is the sensory organ for hearing, just like the eye is the sensory organ for vision. And sensory neural means that the problem could be on the eighth nerve or any of the pathways through the auditory brainstem or in the cortex. So it's a sensory neural hearing loss, basically meaning, you know what, the problem is not in the external ear canal, the problem is not in the middle ear. The problem is either in the cochlea or through the neural system that goes from the eighth nerve through the brainstem up into the cortex. Conductive hearing loss, where is the site of lesion? Is there a problem in the cochlea? Well, if we just use the bone conduction thresholds, they're all better than 25 dB HL. So the bone thresholds would indicate that there's not a problem in the cochlea for the most part. Now, the air conduction thresholds are poorer than 25 dB HL, so that represents a type of loss. It represents that there is a hearing loss. What type of loss is it? Well, we have air bone gaps greater than or equal to 15 dB. That constitutes a conductive hearing loss. The site of lesion is in the external ear canal and or the middle ear. Now over here for this last audiogram, this is the left ear. We have air conduction symbols and bone conduction symbols. Oh, and I'm sorry. Notice in the previous examples we showed you bone conduction symbols that look like this sideways V. These bone conduction symbols are a bracket, and that represents a masked bone conduction threshold, meaning that noise, masking noise, was appropriately placed, delivered rather, to the non-test ear. So if you have a bone conduction, masked bone conduction threshold here, that means that masking noise was delivered to the right ear because the test ear is the left ear. The symbols are always presented for the test ear. So this is the masked bone conduction symbol for the left ear. That's the test ear. Okay, same with this audiogram and same with this audiogram. So getting back to this audiogram, we have an air bone gap, but the bone conduction thresholds are poorer or higher than 25 dB HL. With that, at least the 15 dB air bone gap, that would represent a mixed type of hearing loss. Where is the problem? Is there a conductive component? Yes. So the problem will be in the external ear canal or the middle ear. These are the air conduction thresholds, poorer than 25 dB, and there's an air conduction, an air bone gap. So because we have an air conductive component, we have a sensory neural component, we're going to say this is a mixed hearing loss. Okay, test environments. Test booths are designed to attenuate or reduce ambient noise levels that may otherwise interfere with the perception of the test signals. They are not sound-proof. You could stand outside a test booth, and the patient being tested is listening carefully to these very low-level beeping sounds from the pure tones, and somebody could stand outside the door and scream, and the person inside the test booth most likely will hear the screams if their hearing is relatively normal. So it's not a soundproof booth, it's a sound attenuated test booth. Okay, like I just said, sound booths are not necessarily soundproof. Soundproof test booths are generally designed to minimize the reflections that may interfere with the perception of the test signal and to attenuate external test sounds. The tester should be able to view the patient during testing. That's really important, especially in an ear, nose, and throat, doctor's office or clinic. Sick people come to have their hearing tested, and a lot of times the patient might be dizzy, so they may be experiencing problem with the vestibular system in the ear, in the inner ear, and sometimes the patient can pass out. So the tester should always be viewing the patient. You have to keep an eye on the patient. The patient, however, should not be able to visually determine when the tester is presenting the signals. We don't want to telegraph when we are presenting the test tone. We want the patient to respond to the test sound when it is actually audible. Getting back to that Carhart and Jerger article, and also the guidelines provided by the American National Standards Institute, also called ANSI, or the American Speech, Language, and Hearing Association, also called ASHA. The procedures are outlined for pure tone thresholds. We use the Hewson-Westlake method, also called the down 10, up 5 technique. If the patient hears the tone, the tester will decrease the presentation level of the next tone by 10 dB. If the patient does not, that's where it should say indicate. If the patient does not indicate that the tone is audible, the tester will increase the presentation level of the next tone by 5 dB. The patient instructions. You will now listen to a series of tones. Raise your hand or push a button whenever you hear the test tone, no matter how soft it is. So we position the transducer for air conduction on the left and right ear, or the transducer for the bone conduction threshold behind the appropriate mastoid. The order of test frequencies, according to ASHA 2005, we're going to present 1,000 Hertz, 2,000 Hertz, then 3,000 Hertz, then 4, then 6, then 8, then move down to 500 and 250 Hertz. We start off again with 1,000 Hertz, and we're going to determine the threshold, or the lowest level, where that patient can detect the test tone about 50% of the time. Once we obtain that threshold, then we're going to switch the frequency to 2,000 Hertz and do the same thing. Find the threshold. Then change the frequency to 3,000 Hertz, do the same thing, etc. After we test 250 Hertz, though, we're going to go back to 1,000 Hertz and retest it in order to evaluate for the presence of a learning effect or a practice effect, meaning that when we test 1,000 Hertz for the first time, this is the first experience that the patient has hearing that test tone, and we'll get a certain threshold, and a lot of times when we retest 1,000 hertz, we'll find that that threshold is actually improved. It may have improved 5 or 10 dB. So we need to watch for that learning or practice effects, and we're going to use whichever threshold is the lowest. For each frequency, we're going to begin with the familiarization phase about 30 to 40 dB above an estimated threshold. This is done to allow the patient to clearly hear the test tone before starting the test. A lot of patients have tinnitus or tinnitus, which is a ringing in the ear, or they can hear a buzzing sound. Some patients say they hear a chirping sound. We want the patient to know what the test tone sounds like. So we'll present the tone 30 to 40 dB above where we think the real threshold is. And this is in order to allow the patient to clearly hear the test tone prior to the testing. If the initial stimulus presentation is inaudible to the patient, we'll increase the presentation level by 20 dB steps until the patient responds. Next, we'll decrease the level of the tone in 10 dB steps when the patient no longer responds to the tone. For each frequency, we'll begin with a familiarization phase. Oh, we've already said that. Okay. Sorry, we're going into the wrong direction. Okay, when the patient no longer responds, this marks the beginning of the threshold search phase and represents the beginning of something we call an ascending test run. Each time the patient responds, we'll decrease the tone in 10 dB steps. Each time the patient does not respond, we'll increase the tone in 5 dB steps. A pure tone threshold is defined as the lowest level that the patient responds to at least 50% of the time during a series of ascending presentations, with at least 2 out of the 3 responses required at a single level across a minimum of 3 ascending trials. So here's a little graph. I believe this is taken right from your textbook. Presentation level on the y-axis and presentation trial number on the x-axis. So initially we're going to present a tone. Now notice we don't know which frequency the tone is presented at, but we're going to present the tone at 30 dB and check to see if the patient responds. If the patient raises his or her hand or presses that response button, we're going to say, ah, that was a response. Okay, so the patient responded. Now the next tone will be decreased in level by 10 dB. So it's the down 10 up 5 method. So the tone is presented at 20 dB. Did the patient hear the tone presented at 20 dB? And the answer is yes. So what do we do with the next tone? We're going to take the next tone and present it at a level 10 dB lower. So now we present the tone at 10 dB. Did the patient hear the test tone? The answer is no, with that minus sign. No. So what do we do with the test tone? We're going to raise it up. How many dB? Right, we're going to raise that tone up 5 dB. Did they hear the tone? No. What do we do? Raise the tone 5 dB. So every time we raise it, it's in a 5 dB step size. Every time we decrease the tone, it'll be in a 10 dB step size. Did the patient hear the tone? Yes, the patient heard the tone at 20 dB. So once they hear the tone, we're going to go down 10 dB. Now this run right here, this is called an ascending test run. This is a descending run. We're concerned about the lowest level that the patient hears the test tone across at least 3 ascending runs, and we're looking for the lowest level where they hear the tone at least 50% of the time. So you can see for this these 3 ascending trials, the lowest level that the patient heard the tone, actually it's 100% of the time, right? 3 out of 3, is at 20 dB. So the pure tone threshold is 20 dB HL for whichever test frequency this is. 3 ascending runs going from 10 dB to 20 dB HL, and the threshold is 20 dB HL. Let's look at this test run. Notice that we presented the sound at 30 dB HL, and the patient did not respond. So remember, in this case, when the patient doesn't respond to the first presentation, we're actually going to increase the level by 20 dB. And we'll keep doing that by 20 dB until the patient responds. Once the patient responds, then we will decrease the tone by 10 dB. So it's down 10 and then up 5. Down 10 when there's a positive response, and then up 5 after the patient doesn't hear it. Down 10, up 5, patient still didn't hear it. Up 5, patient hears it. Down 10, no response. Up 5, no response. Up 5, the patient hears it. So you can see here, we actually have 4 ascending test runs. What is the threshold? Recall that the threshold is the lowest level where the patient detects the test tone at least 50% of the time. What is the lowest level where the patient detected the tone? Right, it's at 40 dBHL. So how many times was that? What was the percentage of the time? Well, 3 out of 4 would mean that that's the level where the patient detected it 75% of the time. Does that meet our criteria of at least 50%? Yes, it does. Okay, so the threshold is 40 dBHL. Look at this one. The patient hears the tone at 30 dB. We drop it 10. They heard it at 20. Down 10. They didn't hear it, and then we go up 5. They didn't hear it, go up 5. Didn't hear it, go up 5. Well, that's interesting, because they had responded at 20. Now they didn't respond until 25. Okay, but anyway, they respond, so then we go down 10. They didn't respond, go up 5. They didn't respond, go up 5. Okay, it's at 25 again. Go down 10. They didn't hear it, go up 5. Oh, now they hear it at 20. So we have, what is the threshold here? What do you think? Well, we're going to look at the 4 ascending test runs. What is the lowest level where the patient recognized the tone, or detected the tone, rather, at least 50% of the time? So we have 4 ascending runs. 50% of the time would be for 2 test runs. The lowest level where the patient detected the tone at least 50% of the time is actually 25 dB. Oh, excuse me. Oh, yeah, 25. I just misread what I wrote. Is at 25 dBHL. So the threshold is at 25 dBHL. Why isn't the threshold at 20 dBHL? There were 2 responses at 20 dBHL. The answer is this is not at the end of an ascending run. This is in the middle of a descending run. We're not going to count this. We only count the thresholds at the end of an ascending run. Okay? So that's why the threshold in this example is actually 25 dB and not 20 dBHL. Okay, just like I said, why isn't the threshold 20 dBHL? The answer, there's only one ascending run where the response is at 20 dBHL. So variables influencing thresholds. The patient's response criteria may be strict or lax. A strict response criteria means that there is no response until the patient is very confident that a tone is heard. May result in an elevated threshold. So imagine a patient actually hearing the tone, or they're not really quite sure, but they're going to say to themselves, you know what, I'm not pushing that button, or I'm not going to raise my hand until I'm 100% sure that I hear the tone. This may result in elevated thresholds. A lax response criteria means, you know, even if I'm not really 100% certain, even if I think, well, there's a 25% chance I think I heard the tone, I'm going to keep pushing that button. But this might result in inconsistent or unreliable results. So the patient's response criterion may affect the thresholds. What else might affect the thresholds? Oh, well, this, because we're still talking about the lax and strict responses. A false positive response means that the patient responds when the test tone is not presented. That's called a false positive. We see that with lax response criterion. And a false negative response is when there is no response when the test tone is heard. That's from a strict response criterion. Also, the random nature of the neural noise floor in the auditory system, internal noise due to the ongoing neural activity, may affect the pure tone thresholds. And also the fluctuating noise floor in the test environment may affect thresholds. Remember, the sound booth is sound attenuated, it's not soundproof. If there's a little crowd of people talking and laughing outside the test booth, that elevated noise floor could elevate the pure tone thresholds. That's a problem. Also, the patient's motivation, trying to get a job or trying to win an award from an insurance company for a hearing loss, may affect thresholds. If they're trying to fake a hearing loss, that can elevate the thresholds. It's not real, though. It's due to the patient malingering. The patient's state of attention may also be affected by a lack of rest, illness, medication, distress, worry, pain, mental status. All these things may influence the threshold, and we have to use our clinical judgment to determine if we want to actually stop the test and say, sir, I can see that you're in a lot of back pain, and it's probably affecting your performance with this test. I see a lot of variability in your responses. Why don't we go ahead and reschedule, and we'll bring you back at another day when you feel better. Okay, presentation timing. The stimulus presentations should not be made in a predictable rhythmic manner. You don't want to present a tone in a predictable manner. You don't want to present something like beep, 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 because then the patient can predict when you're going to present the tone. We don't want that to be part of our testing. The patient may respond purely to the timing pattern of the presentations instead of actually hearing the test tone. Tuning fork tests were used in the mid-1800s prior to the use of the audiometer. When in contact with the skull, the sound vibration travels to the cochleae through the bone conduction. Okay, so this is a bone conduction test. It does not represent, we can determine to some degree the type of loss, but not the extent of the hearing loss. Tuning forks are used in a limited fashion to determine the presence of a conductive or sensory neural hearing loss. Again, the degree or extent of the loss cannot be determined with tuning forks. And yes, tuning forks are still used today. There's a test called the Weber tuning fork test, and the purpose is to determine the type of loss for the poorer ear when the loss is asymmetrical. We place the tuning fork at the center or midline of the head or upper forehead, and we ask the patient to report whether the sound is heard in the middle or the right side or the left side of the head. It's useful for detecting a unilateral hearing impairment. We ask the patient which ear is the better ear. If the sound lateralizes towards the better ear, say the patient says, oh, I can hear better outside of my right ear, and we conduct a Weber test, put the little tuning fork on the top of the head, and if the patient says, oh, I hear the sound in my right ear, that is if the sound is heard in the better ear. The poorer, excuse me, let me back up. If the sound lateralizes to the better ear, that is, if the sound is heard in the better ear, the poorer ear may have a sensory neural hearing loss. If the sound lateralizes towards the poorer ear, then the patient probably has a conductive hearing impairment. So this is what a physician could do in the clinic to determine the presence of a possible conductive or sensory neural hearing loss. Actually, if it is within your scope of practice as a speech pathologist, you may be allowed to do tuning fork testing also. A RINA tuning fork test, the purpose is to determine the presence of a conductive hearing loss. We use a loudness judgment. So we ask the patient which location of the tuning fork sounds louder. There's two positions. One, we place the tines, or those two little things at the top of the tuning fork near the opening of the ear canal, and we say, this is position number one, and then we take the stem of the tuning fork and touch the mastoid bone with it so the patient hears through bone conduction. We say, which is louder, position number one with air conduction or position number two with the bone conduction? And if the air conduction sound is louder than the bone conduction sound, that's called a positive RINA, which is actually a good thing. Then we suspect normal hearing or possibly a hearing loss, but with no conductive component. So we would call that a sensory neural hearing loss. If the bone conduction transmission is louder than the air conduction, so they hear better through bone conduction than air conduction, we would suspect that's called a negative RINA, and we suspect a possible conductive loss. The non-test ear should be masked. And then here's a little screenshot from Wikipedia that you should review, and it shows the RINA test and the Weber test and how we can determine whether perhaps the patient has, maybe the patient might have a normal condition or a sensory neural loss in the right ear or a conductive loss in the left ear or a sensory neural loss in the left ear or a conductive loss in the right ear. Of course, in order to confirm that the loss is real, it really is a sensory neural hearing loss or a conductive loss, the patient would need to go through pure tone testing with bone conduction and air conduction thresholds obtained, and the non-test ear would have to be appropriately masked when necessary. And that's the end of our lecture on pure tone testing.